Okay, welcome everybody. It's December 12th, 2023. We're doing a webinar on diabetes and sexual dysfunction through the SMSNA Society. We're really happy and privileged to have a wonderful setup tonight. We have wonderful speakers. We're going to go through each one and give you a little bit of a bio for the speakers tonight. I'm Dr. Seth Cohen, Assistant Professor, Department of Urology here in New York at NYU. I'm co-moderating with Faisal Yafi out of University of California, Irvine. And what we're going to do is try to do fairly straightforward 10-minute talks. We got about 5 of them, and we will get through the talks first, and then we'll do a little Q&A session afterwards. So write down your questions. You can put them in the Q&A chat area, and we will get to them sort of in a row. And with that, Faisal, you want to do the first?
Yeah, thanks. Yep. Thank you, Seth. It's always fun doing moderating with you. So we have a wonderful program. We're starting with the diabetes pandemic, what you need to know with Dr. Dobbs from Johns Hopkins, followed by diabetes and female sexual function by Dr. Yee from Scripps in San Diego. Then diabetes and male sexual function by Dr. Shea at UCSD, followed by diabetes and testosterone by Dr. Andino, recently at UCLA. And finally, by a talk on diabetes considerations in prosthetic urology from Dr. Barnard from West Virginia University. On that note, Dr. Dobbs, I'll stop sharing. Please go ahead and share your screen.
Okay, so what we'll do while this is loading up, I guess I will do a little intro to the bio. Okay, so Dr. Adrian Dobbs is a professor of medicine and oncology and director of the Johns Hopkins Clinical Research Network of the Johns Hopkins Institute for Clinical and Translational Research. It's a multi-institutional collaboration linking academic and community hospitals in the mid-Atlantic United States. Dr. Dobbs received her undergraduate degree from Cornell and medical degree from Albany Medical College, and we're very happy and pleased to have her tonight to present to us. Take it away.
Thank you so much. Does everyone see my slides in the slide view?
We can.
Perfect. Okay. So the title is The Diabetes Pandemic, What You Need to Know. And I thank so much for asking me to speak, because there is so much to know and so much has changed in the field of diabetes. All right, let me go forward here. So I have no disclosures. Basically, I'll be talking about the epidemiology of diabetes, some changes in the overall treatment approach, and then talk about some new treatments. So we still think in terms of these 4 types, type 1, type 2, gestational diabetes, and pre-diabetes, but there are some sort of subtypes, such as maturity onset diabetes of youth, but they're not as important as thinking in terms of these other major 4 categories. I think we're all pretty familiar with the fact that this is a changing scene. What you see on the left here is the prevalence of diabetes in 2004, and it's color-coded to be the darkest colors having the highest concentration. And here you see on the right what it's like in 2021. So that today there are 38.5 million people, or 11.5% of the population, that have diabetes, and 23% of these people do not know it. And obviously this change is related to the fact that obesity has grown tremendously during this time. So we learned a lot about type 1 diabetes. I'm not really going to distinguish so much between the two, but even type 1 has had amazing changes. There's a genetic risk, an immune activation stage, immune response. Then there's truly stage 1, where there begins to be beta cell decline. And what's very new here is the fact that anti-inflammatories are being given to patients when they reach stage 1 in order to prevent the progression to stage 2 and 3. Now, in stage 2 diabetes, it also is a progression as well. It's not as if one wakes up in the morning and all of a sudden they have type 2 diabetes. So on top here, you see the plasma glucose levels that slowly begin to rise. Here's the fasting glucose, here's postprandial glucose, and here is the years prior to the diagnosis. It could be as long as 20 years. Here's the actual diagnosis. and here is what happens after the diagnosis of diabetes. And this correlates very closely to the insulin resistance and insulin secretion. So what's happening in the beginning could be minus 20 years is an increase in insulin resistance, an increase of compensatory insulin secretion. And then slowly what happens is the resistance stays steady, but the insulin secretion begins to fall. And that's when people actually become diabetic. Now, there is a natural history of diabetes that occurs. So here is the normal situation of fasting blood glucose less than 100, a random blood sugar less than 140, and an A1C less than 5.7%. Here you see is pre-diabetes, where the fasting blood sugars now are 100 to 125, and the A1Cs are between 5.7 and 6.4%. And approximately 50% of the pancreas is still working. One can go from pre-diabetes to normal. However, once diabetes fully develops, and here the definition is a fasting blood glucose at 126, random greater than 200, and an A1C of 6.5%. In this situation, 20% of the pancreas is actually working, and one really cannot go back to a pre-diabetes state. And all of this occurs over years or decades of life. Now, one thing important to emphasize with diabetes that there is that healthcare disparities plays a big part here. Here is, if you look at non-Hispanic whites, the age-adjusted percent of patients with diabetes is 7.6%. And this increases to the point that American Indians and Alaska Natives, it's 15.9% of the population greater than 20 years of age will be diabetic. So I think that there's a lot of emphasis on really how to change some of the healthcare disparities that exist within diabetes. So here is changes in the treatment approach that has really dramatically changed in the last few years. Thinking in terms of the complications, that it's looking much more holistic, so to speak. And 52% of diabetic men, as an example, have erectile dysfunction, and that's a big part of what we'd be talking about this evening. But visual disability is 10%, kidney disease is 39% who have CKD, having some kind of major cardiovascular disease is 50%, 90% are overweight or obese, 22% smoke. So it's really looking at diabetes as a multi-system disease and not just something focused on what is the blood sugar. In fact, there have been many studies that have looked at the blood sugar alone, and it really made a difference. It might have done something for microvascular disease, but not much when it comes for macrovascular disease. So here's just some of the approaches and the changes that can occur. And each one of these really can have an effect on sexual function in diabetes. So there's a decreased amylin, beta cell secretion, 80% loss gives you the diagnosis. There's increased glucose production in the liver. There's an increased lipolysis that occurs. There is a increased glucagon secretion, a decrease in gut hormones, and a decreased satiation neurotransmission that occurs as well, and increased renal response. So when we're talking about erectile dysfunction and diabetes, we have to be thinking about all of these different components. There's the comorbidities of hypogonadism, of metabolic syndrome with obesity, hypertension, dyslipidemia, obstructive sleep apnea, UTIs, depression, and then there's more of the direct complications that we've always thought of, which is a cardiovascular event, and then microvascular disease of nephrology and neuropathy. So all of this really is part of the picture in trying to intervene early to help with erectile dysfunction and sexual dysfunction in men who have diabetes. And so therefore, any intervention that we're thinking about has to address all of these multiple components: glycemic management, blood pressure management, lipid management, agents who affect cardiovascular disease and kidney function, lifestyle modification, diabetes education. It is not just glucose when we're talking about the approach to diabetics, or we're talking about the approach to sexual dysfunction. And this has been shown in a few studies that people in general are in poor control for their cardiovascular disease. And this is the percentage of patients. We're looking at A1C level, LDL level, or blood pressure. So if you look at all of these factors combined, it turns out that really 25% of the diabetic population are not where they should be. Their A1Cs are too high, their LDL is too high, their blood pressure is too high, and each of these need to be approached in order to help the patient. So what are these new treatments that are gearing towards everything, all these different factors? Well, the first major change, I think, has been the issue of self-monitoring. There have been so many advances in the issue of continuous glucose monitoring. This is just a picture I have of a Dexcom G4. We really have a Dexcom G7 now. It's something that's wearable. It's linked to people's phones. It's linked to the physician. And it has been an amazing step towards better control, especially when these are linked to an insulin pump. So here is really your artificial pancreas, in which it can sense the blood sugar and infuse just the right amount of insulin based on the insulin sensitivity, what the blood glucose levels are. Now, medications have a dramatic change. We no longer think in terms of monotherapy, but really thinking in terms of adding 2 or 3 drugs. And this is a list of really 11 classes of diabetes medications that are now routinely used and mixed around. The first is metformin, that have been around forever. There's the diones that aren't really used that much. Sulfonylureas are still in the picture because they're very inexpensive. The DPP-4 inhibitors, such as Januvia, it's a $1 billion drug, and it has some effect on increasing insulin sensitivity. There's multiple kinds of insulins that are out now, each with different peaks. Obviously we haven't used NPH in many years, but the use of insulin pumps in order to really give the exact amount of insulin at the exact amount of time. SGLT2s, such as Jardiance, has a primary effect on kidney, and I'll show you that in a few minutes. And then the latest drug, which has just taken the whole market, by storm, is glucagon-like peptide 1 receptor agonist, GLP-1. An example of this is Ozempic. So now in treating diabetics, we're thinking in terms of choosing among the available medications that require considerations of the benefits, the mode of actions, the class, the adverse effects, and what are the costs. So I'll start out with SGLT2 inhibitors. They work by blocking the reabsorption of glucose at the proximal tubule. So instead of glucose being reabsorbed, there's increased glucose excretion. And this is an important way to drop the blood sugar levels. There are some complications with UTIs, but it has been very effective in a population of people. And not only does it work to lower glucose and increase excretion of it, but there's also beautiful data on decreasing hospitalization rates, decreasing blood pressure, and it's now being used in patients who have kidney disease even without seeing diabetes. And this is hospitalizations for heart failure, and this is a hazard ratio, and all of which are to the left, showing that it is protective. Now, incretins, which is the GLP-1s, what you see here is the incretin mechanism of action. People eat food. Normally, the small intestines will secrete these GLP-1s in response to this food. And GLP-1s have multiple effects first in the brain by decreasing appetite. It affects the pancreas by stimulating insulin secretion, and it slows gastric emptying. It also will work on the pancreas to suppress glucagon secretion and decrease glucagon while increasing insulin. Now, I do emphasize that this is probably a major reason why people have such dramatic weight losses is because of the slow gastric emptying, and this also causes some of the nausea that these patients complain of. But you see that incretins are working at multiple different organs. This is what it looks like. They come in these pre-loaded syringes. There's multiple ones that are now on the market. The insurance companies are trying very desperately not to pay for this. And it's almost impossible to get it for just obesity. But if there is diabetes and obesity, then these drugs can be just can have a dramatic effect. And this is not expected for you to read it, but what you see here, this is the change in weight with various hypoglycemic medications. In gray here is insulin, where you see there is an increase in weight. And that has always been something we've seen for years. It has many effects to be obese, particularly when we talk about testosterone and metabolic syndrome. And here over on the right side are individuals who have lost weight, and where they lose about 10%, they lose at easily 10, 11 kilograms. And the most pronounced drug is that of Mounjaro. Here, so you see this just difference in weight based on what the drug treatment is. Now, the prescription rates for GLP-1 has changed dramatically over the last few years. More than 5 million prescriptions have been written for Ozempic, Wegovy, and Mounjaro. This is up from 230,000 in 2019. In fact, there really is a national shortage now. The cost is $1,000 per month, and there's many people who are paying out of pocket for this. But the concerns are for GI distress, loss of muscle mass, and the fact that this is really a lifelong drug. Now, what's exciting about this is it may have also direct effects on sexual function. We don't know enough about it now, but there's data coming out that SGLT2s will have an effect on the endothelial surface. It will increase testosterone. It will increase testosterone levels, improve erectile function. So I think it'll be interesting to see how this changes over the next few years and whether or not these drugs are really beneficial for not only blood sugar control, not only for weight, but also having a direct effect on sexual function. So in conclusion, there's the expectation of increased rates of obesity and diabetes. And this, unfortunately, is also fraught with significant healthcare disparities. The overall approach to diabetes has migrated away from simple glucose control. We now have new monitoring and medications that have dramatically changed the treatment landscape for people with diabetes and obesity. The overall benefit of GLP-1, particularly for weight, is very strong. And we really await data on whether or not there's a specific direct benefit of this class of medication on diabetic complications. Thank you very much.
Wonderful. Great talk. Timely. I think very interested. I know I have a lot of questions, but of course we're going to keep going and get through all the speakers tonight, and then we'll open up to some questions afterwards. Up next, Dr. Alyssa Yee. Let me just give you a quick bio for everybody who may know you or don't know you yet. Dr. Yee is a sexual medicine physician and reconstructive urologist who completed her clinical fellowship at SDSM, San Diego Sexual Medicine. That's my alma mater as well, under the mentorship of Dr. Irwin Goldstein. In her fellowship, she was awarded the SMSNA Foundation Research Grant, and she's a longtime New Yorker. She's an esteemed graduate of SUNY Downstate College of Medicine and holds her bachelor degree in architecture from Barnard College at Columbia University. Dr. Yee, welcome to the podium. We're glad to have you tonight.
Thank you so much for this opportunity and invitation to speak about something I feel very passionately about: female sexual function, and in this case, female sexual dysfunction in the setting of diabetes. I have no disclosures. I will say that some of the words that will be used or seen on the screen today do not fully reflect the entire spectrum of gender identity. Whenever I talk about female sexual function, I really like to emphasize the domains of sexual function. This is true for all patients, but especially in vulva owners and female sexual function, we want to look at desire, arousal, orgasm function, but especially this last one, pain, because it isn't just what we think of as dyspareunia. There are many different aspects to the anatomy which can bring about pain and therefore sexual dysfunction. I'm sure many of you have seen this before, this particular slide and study by Dr. Lahman and colleagues. It's old data, but looking at the reported sexual dysfunction between male patients and female patients across the US. And I think it's really important to look at the most prevalent dysfunction that was reported by women was actually lack of interest. But then there's other particular things like pain specifically is very different and way more common in female patients than in male patients during sex. Additionally, there's always this idea of the orgasm gap, and the inability to achieve orgasm is very common for women as opposed to for male patients. And then down here, you'll see this idea that men being unable to keep their erection is only for the male patient, but I would argue, and we'll talk about, that erection is actually present in female patients and vulva owners as well, which can also lead to a decrease in pleasure or inability to achieve orgasm. And then, yes, this issue here of lubrication. And I put these stars here between the particular things for women, the most common or the most different, and how they can influence each other. So when you experience pain over time, you may have less interest in sex. Similarly, with decreased pleasure, decreased ability to orgasm, again, can decrease the interest in sex, and vice versa. If you don't have a lot of interest to begin with, then you may not actually have great orgasm ability. And similarly with lubrication, pain, etc., can lead to a decrease in interest. Now, looking actually at a systemic review and meta-analysis data, what was reported in many studies of the prevalence of female sexual dysfunction in diabetic patients is very widespread. So from 20 to 80%, that's a very large and widespread. And I would argue that even regular female sexual dysfunction at 40% in the general population, that's quite significant. But what can account for it being anywhere from 20% to 80% of diabetic patients with vulvas? Well, in these studies, we found that there were, first of all, fewer about diabetic women and sexual function than in diabetic men. And often our tool, which we use to screen for sexual function, the FSFI or Female Sexual Function Index, has been used at different cutoffs to describe dysfunction. So different scores were used between these studies. And then some of these measures are actually very penetration centric, whereas that's not always the way that some of our patients are having sex, and therefore it doesn't accurately reflect their function. And a lot of these studies were done in very small study groups. So like we just saw, diabetes can affect many different aspects of the body. There's microvascular, small nerve dysfunction, hormonal derangements, and also psychological and mental health sequelae of diabetes. And this is really important. We were just talking about the negative effects of some of these treatments on sexual function or health, some of the consequences. And I really like to underscore the difference in functional anatomy of the vulva versus the penis and how that might be involved with diabetes. So normal sexual response requires that the somatic and the autonomic nervous system are firing in all cylinders. You need smooth muscle relaxation, vasculature to increase genital blood flow. And then diabetes can affect all of this. It can reduce hydration of the membranes, which then dryness of any kind can lead to dyspareunia. Lubrication from the secretory glands, and we're going to go over the difference there, is also affected by diabetes. And then our diabetic patients who are already slightly immunosuppressed or susceptible to infections, that can lead to complications and dyspareunia. And then, of course, altered sensorium from small nerve damage can really affect the way that we perceive sexual stimuli. This is just a reminder slide of what happens in a normal menstrual cycle when everything is happening and occurring in a normal way. And we know that polycystic ovarian syndrome has an association with insulin resistance. There certainly is a derangement in the hormone levels in some of our patients who are insulin resistant. So looking at our most commonly reported dysfunction in female patients, HSDD or hypoactive sexual desire disorder, low libido, decreased desire, all of that can be in part affected by diabetes for the many reasons which you could have low desire, but certainly ovarian function and hormones can be disrupted by diabetes. And that only gets worse as you have a normal ovarian decline in perimenopause and menopause. So there's always this subtext of the decline of the ovaries, but if you have diabetes on top of that, then your ovarian function would be potentially even worse. And we see that there is an increase in depression and anxiety in diabetic patients with the complexities of their health, the great burden that they undergo with having to be treated or having consequences of being diabetic. And that a lot of our studies have shown that female sexual dysfunction is strongly linked to psychological factors, especially depression, even more so than organic factors in some of our studies. So then looking at functional anatomy, it isn't a huge leap to go from the dysfunction that we know occurs in microvascular disease of the penis to looking at microvascular disease of the clitoris. And you can see the cross sections are very analogous. You have vascular function here, which will increase engorgement. So again, erection is not only of the penis, and erection of the clitoris plays a role in sensation and orgasm. And this looks like a diagram you've seen many times over. This is a cross-section of the clitoris, though very similar to the cross-sections you've seen of penile tissue with two corpora here. And you can imagine diabetes can affect not only the nerves, but the vasculature and therefore erectile function tissue. So moving on to arousal lubrication and then eventually pain. There is a huge host of literature looking at oral health, salivary glands, even parotitis. Those are things that are affected in diabetic patients all the time. And so it's not a huge leap to say secretory glands certainly are affected by diabetes, and particularly the secretory glands, which allow for arousal lubrication at the introitus. So the Bartholin's gland, the minor and major vestibular glands are highly active during arousal lubrication. That sticky, clear, viscous lubrication is very different than vaginal transudative lubrication. We'll talk about that in a minute. But our diabetic patients may have dysfunction or damage to the gland parenchyma, the alterations in microvascular disease that then affect these glands. And overall, many of our patients are dehydrated. Even some of their treatments may make them dehydrated. And so if you're dehydrated, then your glandular function is also going to be decreased. When you have decreased lubrication, sex may not be as comfortable or can cause pain. And so stomatitis or xerostoma or dry mouth is something that a lot of diabetics will report. And then it's not so strange to see very dry vaginal mucosa in these patients as well. And decreased vascular relaxation will also decrease the amount of transudative fluid that is emitted in the vaginal canal. That fluid is also for sexual lubrication and different and comfort as well, but very different than the glandular secretory discharge that happens during arousal. Both can be affected by diabetes. And then, of course, our diabetic patients being susceptible to infection, slightly immunosuppressed, and often one of the complications of having diabetes is candidiasis in many different places. Thrush, but certainly vulvovaginal candidiasis. And unfortunately for these patients, it can be recurrent. The most common candida that we see is Candida albicans, but in our diabetic patients, particularly type 2 diabetes, there are a lot of Candida glabrata vaginal infections. I'm sure some of you have seen this in your practice. And while it tends to be slightly less aggressive or virulent, it is also more resistant to our normal treatments that we readily use in Candida albicans. And so it can be hard to eradicate in these cases. Other things that can happen in our patients who have diabetes, like we were talking about the treatment Jardiance causing in UTIs, or our patients who get recurrent UTIs and diabetes, the antibiotics that we use then also kill off the lactobacilli and good flora of the vagina, leaving our patients to have more risk for vulvovaginal candidiasis. That in turn, those symptoms equal pain, and other factors can also increase their risk of vulvovaginal candidiasis, including oral contraceptive use. And I wanted to highlight that, and this was reported at our most recent meeting, some of the treatments that we use for vulvovaginal candida, like miconazole, all the over-the-counter creams that you apply topically to get rid of the yeast infection, in some patients can cause a more chronic and permanent dysfunction or pain syndrome with sex called neuroproliferative vestibulodynia. Some of these patients have an allergic reaction to the actual base or the treatment itself. It's probably not the agent, but maybe whatever is in this topical cream has stimulated it, resulting in an accumulation of mast cells that then are activated and release cytokines, nerve growth factor, and then there's this overproliferation of nerves, particularly in the vestibule. This was reported by Dr. Bornstein and colleagues back in 2004. This is something I see quite a bit of and treat, but unfortunately the treatments are no longer just a topical cream that you use temporarily. They require a lot more complex treatment and can live with pain and go undiagnosed for a very long time, particularly sexual pain. So in conclusion, diabetes really can affect all the domains of female sexual dysfunction through many different avenues. The reduction of secretory lubrication, of hydration of the membranes of the vulva, which then lead to dyspareunia. The infection risk itself can lead to pain or decreased function sexually. Of course, neuropathy can decrease sensation to sexual stimuli. And the depression that many of our diabetic patients have is highly associated with female sexual dysfunction. And of course, we need larger studies and more studies to break down really how sexual function and diabetes in our female patients is at play. So thank you very much.
Great talk, insightful, academic. We really appreciate it. We learned a lot. Thank you. I'm sure a lot of people will have questions. We could throw those right down in the Q&A if you do. And like I said, feel free to start throwing questions in the Q&A as they pop up in your mind. You don't have to write them down necessarily, but we ask you to so that we can sort of get to your questions in order at the end of each talk. So we're going to move right along to Dr. Mike Shea's topic. Let's load him up there. Dr. Shea completed his residency training at George Washington University and did a fellowship in male reproductive medicine and microsurgery at Baylor College of Medicine. He's currently a professor of urology at UCSD and director of Men's Health Center and High Complexity Andrology at UCSD. Dr. Shea is a good friend, and we welcome him back to give us a talk tonight. Thank you, Dr. Shea.
Thanks for having me. Can you guys see my slides okay?
Yep, you're ready to go.
All right. So these are my disclosures. For sake of time, we'll just kind of jump right into it. So we know that diabetes can affect many aspects of male sexual function. In this table is trying to show a survey of approximately 585 men with diabetes and specifically addressing their sexual function. So as you can see here, about 45% of the respondents reported that they're having some level of sexual bother within the last 4 weeks. About 51% of the respondents reported some levels of erectile dysfunction within the last 4 weeks. And about 37% of the respondent reported decreased libido in the last 4 weeks. And 32% of the men completed survey mentioned some level of ejaculatory dysfunction. So for the purpose of the talk, we will focus on these three sexual dysfunctions, and we'll try to, keep us on time. So we all know that erectile dysfunction is very common in diabetic men. Approximately 60% of the guys with diabetes does report some level of erectile dysfunction. And there actually, it's higher proportion in type 2 versus type 1 diabetic. And most men with diabetes develop erectile dysfunction approximately 10 to 15 years earlier than the men without. And there is some interesting geographical data showing the highest prevalence of erectile dysfunction in diabetic men in the continent of Africa and Asia, and at approximately 71 and 67%. America somewhere, North America somewhere in the middle, about 34%. So why do men with diabetes get erectile dysfunction? As Dr. Dobb alluded to, this is a systemic disease, and it can affect both the vascular and the neural pathways for erectile function. And the most common finding in men with diabetes is what we call endothelial dysfunction, where the vasculature does not dilate or contract appropriately. There's many pathophysiology for this. There's abnormalities within the rho kinase pathways been shown. There's also increased levels of inflammation in diabetic men. And we also know that men with diabetes also suffer from hypogonadism, where testosterone does have some anti-inflammatory properties. From the neurological side, there's decreased sensory inputs to the reflex arc of the erectile centers. And there's also decreased signals coming from the pudendal nerves to allow for the proper contraction of the muscles, such as bulbar spongiosus, to maintain erection. And we now know that erectile dysfunction is a risk factor for cardiovascular disease. On average, a penile artery is approximately 1 to 2 millimeters in size, where your coronary artery is approximately 3 to 4 millimeters. Therefore, it's been shown that ED precedes any coronary artery symptoms by approximately 3 years. So we now know that this is a SMA talk. Everybody knows the treatment for erectile dysfunction. There's medications, there's intracavernosal injections, there's MUSE, there's vacuum reduction device, and then surgery. We know that men with diabetes don't always respond well to medical treatment. Therefore, they're more likely to receive surgical treatment. And I know later on the speaker will talk about, some of the potential complications men with diabetes can experience with surgery. But I thought it'd be interesting to look at in men who had poor response to PDE5 inhibitor due to their diabetes, what's the effect of their diabetes medications? So this is kind of what the evidence is available. So metformin has been shown to improve BMIs, improve men's insulin resistance index, and also their response to PDE5 inhibitor as measured by IEF5. The different class of drug like the pioglitazone, I think the brand name is something like Actos, has been shown to improve the responsiveness of diabetic men to PDE5 inhibitors. The SGLT2 inhibitors has been shown to improve erectile function in animal studies. The hottest and newest DT4P, 4I, and also GLP-1 has been shown to improve erectile function and testosterone levels in men who also experience weight loss. And lastly, insulin has been shown to increase the expression of androgen receptor in animal models as well. So these medications is also important in helping these men with their sexual function. And now there's even animal studies that show PDE5 inhibitor can potentially improve diabetic-related cardiomyopathy in the animal model as well. So next we'll go over libido. We know that in the setting of metabolic syndrome, hypogonadism is very common. It's been reported in approximately a quarter of the men with diabetes. And on average, diabetic men had a baseline total testosterone of approximately 2.5 nanomoles per liter lower than those with men who do not have diabetes. We also know that diabetic men are more likely to suffer from depression. And this appeared to be a bidirectional relationship, approximately 30% more increased risk. So to address their poor libido, of course, we always want to correct any underlying endocrinopathy. And these men doesn't only have hypogonadism, they also can have thyroid dysfunction and other endocrinopathy that should be addressed. We also talk about lifestyle and dietary modification. I'll go over a little bit later in the talk. Psychotherapy. We also need to review the medications because some of the medication can cause side effect of poor libido. And sleep evaluation in men with metabolic syndrome. A lot of them also have concurrent sleep apnea. And we know that obstructive sleep apnea is a risk factor for poor libido, and correction can improve their sexual function from that standpoint as well. Next, we'll go over ejaculatory dysfunction. We know that men with diabetes are at risk for different types of ejaculatory dysfunctions, and some of the risk factors includes age greater than 50, duration of their diabetes of more than 10 years, hemoglobin A1C greater than 7, and other concurrent sexual dysfunction put them at an even higher risk for ejaculatory dysfunction. So there's thought to be many pathways. We know that on the peripheral side, there is a reduced sympathetic drive. There's failure of the internal urethral sphincter relaxation and proper function, along with the reduced contraction of the bulbospongiosus muscle, as I mentioned earlier, as related to their neuropathy. But centrally, there's even studies looking at decreased dopaminergic transmission and also decreased serotonin signaling. And these are all also important for both orgasmic function along with their ejaculatory function as well. So the three main type of ejaculatory dysfunction that men with diabetes suffer are premature ejaculation, retrograde ejaculation, or delay and anejaculation. And these are some of the possible treatment options. For premature ejaculation, we use PDE5 inhibitors, we use psychotherapy, we try to improve their glycemic control, or these are kind of some of the starting points. In men with delay or anejaculation, cabergoline can be tried, and some of the bupropion or change them to a better types of SSRI with decreased sexual side effect can also be attempted. And penile vibratory stimulation has also been shown to improve their anejaculation or delayed ejaculation. And the more commonly I see in my fertility practice are retrograde ejaculations. And sometimes we put on medications such as sympathomimetics and anticholinergics to really close your bladder neck to improve antegrade ejaculation. But oftentimes, if it's not successful, we also perform retrograde sperm collection after alkalizing their urine to enable assisted reproductive technology. So we know there's importance in diabetes management to improve their sexual function. What has lifestyle modification been shown? So studies have shown that intense, moderate physical activity is associated with lower risk for erectile dysfunction and premature ejaculation. Just 1 year after smoking cessation has been shown to improve erectile function in both diabetic and non-diabetic men. Excess alcohol intake, greater than 20 drinks per week, is associated with erectile dysfunction, organic dysfunction, and low libido. So these are some of the evidence-based lifestyle modification. We also know that by effectively manage their diabetes and correct their endocrinopathy, we can also reduce complications of diabetes. In the recent T4DM study, we showed that testosterone replacement therapy can reduce the progression of men with pre-diabetic to diabetes, along with improving the glucose control in men with diabetes. We know that medication adherence and routine monitoring is very, very important. That's why things like continuous glucose monitors so useful in these patients. And we know that elevated A1C is a risk factor for erectile dysfunction and orgasmic dysfunction in type 1 diabetes. So if we can keep the A1C below 7, they also do better in their sexual function. So I think it's important for us to really acknowledge and address some of the psychological impact of sexual dysfunction. As I mentioned, depression is not uncommon in the diabetic patients, and we really need to encourage open communication and be able to discuss all the available treatment, because we do have a lot of good treatment options for them, both from a sexual function standpoint and also from a diabetes standpoint. And hopefully, using their sexual function, we're able to really improve their management of their diabetes as a potential incentive as well. So this is my last slide. Sexual complication is common in men with diabetes, and it's important to really proactively manage their diabetes to really improve their overall health. Thank you.
Thanks, Mike, for a wonderful talk. Very informative. And again, my commentary will not be as eloquent as Dr. Cohen, as I do not host a radio show. All right. Next up will be Dr. Andino. So Dr. Andino is a rising star in SMSNA. He did his residency at University of Michigan, and did his fellowship in male reproductive medicine and surgery at UCLA with Dr. Mills and Dr. Eliswarapu. And he will be talking to us today about diabetes and testosterone. 1, Floor is yours.
Thank you very much. You guys see the slides okay? Wonderful. Well, thank you all for the opportunity to be here tonight and to talk about this topic. It's nice to be right in the center, and it'll kind of connect some of the things we've already heard about in terms of prevalence, some comorbid conditions, but how this all comes together and affects testosterone, testosterone deficiency, and hypogonadism is something I hope to highlight. I have no disclosures. And really, if we just right off the bat kind of look at the prevalence again, Dr. Dobbs highlighted that 38.4 million people in the United States are affected by diabetes. But if we look at this Lancet paper and take even a broader lens, that's 529 million people in the world. So an overall age-blind prevalence of 6.1%, and this is with very recent data from 2021. And if we look at across age groups, we see a difference and we see a rising prevalence. So for example, in high-income countries, including the United States, already starting at age 45 to 49, it's almost 10% prevalence. Even higher in Latin American countries. I know we have many SLAMs and members that are part of the SMSNA from Latin American countries and the Caribbean. And as we look over the graph, we really see that by 65 to 69 years of age, that prevalence shoots up. It's getting close to 25, 26%. And again, the Latin American and Caribbean countries is even higher. And what drives a lot of this, Dr. Dobbs hinted at this, but I thought this graph was pretty impactful, particularly in the last 20 years, and this graph has a projection going out into 2050, it's really the change in type 2 diabetes. Type 1 seems to be staying relatively stable, but you can see a pretty sharp slope in terms of the rising prevalence of type 2 diabetes. And in this study, they really connected that with elevated or high BMI. So patients being overweight, patients being obese, this really accounted for almost 50% of disability adjusted life years. And we saw just earlier today that in some studies, that association between diabetes and obesity can be as high as 90%. And we can kind of hone in on this in terms of the US. So this is a New England Journal of Medicine paper that estimates the prevalence of obesity out to the year 2030. And it's just expected to continue worsening. And just like there's health disparities and health inequities in the realm of diabetes, if we look at obesity, we see some of the same trends. And again, this just really highlights that these two conditions are comorbid and they tend to occur together. We've seen already slides that look similar to this, but just again, focusing on the testosterone and hypogonadism aspect, when we look at metabolic syndrome, obesity, diabetes, we tend to see a pretty similar phenotype over and over again in our clinics. There's decreased testosterone, decreased sex hormone binding globulin, but interestingly, there seems to be a dysregulation or underregulation of the HPT axis. Despite having low testosterone levels, LH is staying normal. So it's inappropriately normal for the levels that the body is seeing compared to other patients. And this is, of course, associated with increase in visceral adipose tissue, that insulin resistance that Dr. Dobbs highlighted for us at the beginning of our talks today, and again, this aberrant glucose metabolism. But importantly, we need to think about how these things impact the diagnosis and the management and potentially even the screening of low testosterone. I just want to highlight these two different studies, one from our endocrinology colleagues back in 2013 and a more recent study by Dr. Ramasamy and his team at Miami, that when they looked at changes over time in testosterone in men, it really seemed to suggest that it wasn't just age alone, but really these comorbidities that impacted things. So for example, this is one of the conclusions. While life expectancy is increasing, we have an aging population in the US and elsewhere in the world. The rising rates of diabetes, dyslipidemia, and obesity are going to result in more and more men having issues with testosterone deficiency and symptomatic hypogonadism. And importantly, it does seem to be a bidirectional relationship. Just like Dr. Shea mentioned in his previous talk with some of the sexual dysfunction, we really see this as well in terms of diabetes and testosterone levels. So we know that there's an association. Men who are obese, who are diabetic, are much more likely to have low testosterone. Or here, a group did a very interesting study that kind of highlights how actually using testosterone therapy can help improve some of these factors and potentially improve this patient population. So this is a randomized, double-blind, placebo-controlled trial, and they had 1,007 men. They were randomized to testosterone undecanoate injections or placebo. And importantly, look at these inclusion criteria. So men 50 to 74 years of age, they certainly have an elevated waist circumference, but they did not only include patients who qualified for testosterone deficiency. The actual study protocol was using 14 millimoles per liter, but when translated to nanograms per deciliter, you see that the testosterone was actually as high as 403 for the cutoff. And all these men were recently diagnosed with type 2 diabetes or had recently taken a test of impaired oral glucose tolerance that just diagnosed them with diabetes. And the treatment and placebo arms, they received injections at baseline at the beginning of the study, at 6 weeks, and then every 3 months for 2 years. And the results were very impressive. You know, the rates of type 2 diabetes based on oral glucose tolerance tests really were reduced by essentially 40%. So these rates at 2 years were 12% in the testosterone therapy arm and 21% in the placebo arm. And interestingly, this sub-analysis highlighted some of the changes in body composition. And this is what the authors think and suspect that was very important in finding, in identifying these findings. We see that for the placebo group, and all these men were in a lifestyle program in addition to being randomized to testosterone or placebo. But in the placebo group, there was a drop in fat mass with this lifestyle program. That's great, but they also had a reduction in skeletal muscle mass, and grip strength actually went down. In contrast, when we look at the testosterone group, we see that they lost significantly more fat mass, but they maintained, actually even gained some skeletal muscle, and their grip strength went up. So potentially these changes in body composition that were improved in the testosterone arm could have contributed to this reduction in diabetes rates. So not only is there an association in terms of diagnosis, but something to consider in terms of treatment for patients who have both diabetes and testosterone deficiency. And why is this webinar and everything that we're talking about today so important? Well, really, this all kind of fits within the context of the recently published TRAVERSE trials. So we have reassurance. We have a little bit more data, a little bit more information. Many urologists in the sexual medicine realms have felt comfortable managing testosterone replacement therapy, even for patients who may have some cardiovascular risk factors. But now with over 5,000 patients, this randomized control trial really helped reassure us that the cardiovascular risk may not be as concerning as some of those early mid-2010 studies suggested that led to the FDA Black Label warning. But what are some challenges in terms of diabetes, testosterone, managing testosterone deficiency? Well, of course, the modality of receiving testosterone replacement has been a challenge historically. Topical gels, patches, injections. Some patients are simply not interested. They're kind of thrown off that there isn't a pill. Thankfully, we have some newer options, but this goes into this next point, accessing things like the Natesto intranasal gel, the oral testosterone formulations that are now safe for liver metabolism. If insurance coverage is an issue, if prior auth makes it challenging to get, if the only way is using compound or cash only options, we know that there's going to be many patients left behind. So once again, health equity, just as discussed with things like Ozempic, really comes into play again in the realm of testosterone. On the other hand, the positive side of access is the pandemic has really pushed the envelope in terms of using telehealth to try to overcome geographic barriers. So this seems to be a positive aspect that has come out of the last few years, although everything remains in limbo in terms of reimbursement and flexibilities. What is the duration of benefits? You know, as soon as you cease testosterone therapy, is that risk going to come back? Is the diabetes, obesity, et cetera, going to just bounce back? This remains a question not only for patients on Ozempic, but also patients who are being managed for testosterone in terms of in diabetes, especially because we know that if a patient is on testosterone therapy for a long period of time, it may take longer or they may not be able to recover their own testosterone production. So this really goes into that HPT axis suppression. What is the role of selective estrogen receptor modulators, aromatase inhibitors? How do we combine this with lifestyle? It would be really interesting to see a study that looked at how these different class of medications, oral medications, could potentially have a positive effect on younger patients with diabetes and really focus on an aspect of prevention, particularly if we can capture pre-diabetic patients where we know that we can go back to normal. Is this something that we should be looking at and trying to intervene in our younger populations? And fertility to me has many parallels to ED, particularly in the realm of prediabetes and diabetes. If a patient who's young comes in and they're trying to achieve fertility and we're able to diagnose them with hyperlipidemia, elevated blood pressure, and in this case, prediabetes, elevated blood sugars, or hemoglobin A1C, it really gives us an opportunity to try to capture this early on and hopefully prevent full-on type 2 diabetes from developing down the road. And as a society, not just the Sexual Medicine Society, but in the United States in general, it remains a challenge. How do we, as fellowship-trained providers, deal with the problems with predatory practices? There's all these direct-to-consumer telehealth companies now that provide testosterone without appropriate monitoring or levels ahead of time. There's cash pay clinics that really just alter the public perception of what is normal and what is appropriate, and also patient expectations. When they come to us and they've been managed in one way for a long time, it can be really hard to hit reset and use more evidence-based, safer approaches. And lastly, dissemination. That trial from only 2 years ago, a fantastic study, very well done, I had not seen until I was preparing for this webinar. The Traverse trial, those findings have been discussed at the SMSNA and within our circles, but how do we get that out to the community, to other urologists, to PCPs, APPs, cardiologists, so that people are aware that we can use testosterone to help treat patients in this population who also suffer from diabetes. And with that, please let me know if you have any questions, share them in the chat, or we'll talk about them at the end. And thank you again for your time.
Thank you, Juan. Wonderful talk as usual. Last but not least, we're going to go to John Bernard. And as John is loading up his slides, John is from West Virginia through and through, medical school and residency at University of West Virginia. Did his fellowship, like I said, at UCI in reconstructive urology and prosthetics. And he serves a population of 2 million people in the Appalachia with regards to upper and lower reconstruction, upper and lower urinary tract reconstruction and prosthetic urology. We're looking forward to your talk, John.
Thank you very much. Can everyone see me and see the slides?
Yes.
Okay, perfect. So thank you, everyone, for the opportunity to speak today. I certainly learned a lot from my colleagues, and thanks to everyone watching live who stuck around for the last talk, which is going to be considerations in prosthetic urology. I have no disclosures to report, other than I do live in West Virginia, and as we can see here, diabetes is extremely prevalent. Today, I'm going to be discussing diabetes as a risk factor for implant complications, infectious complications, in particular, some issues with the biomarkers about glycemic control and how that may come into play with predicting infectious complications. Some differences in antimicrobial prophylaxis in our diabetic population, and then briefly some non-infectious complications and sort of a case of how to avoid catastrophe. And sort of most importantly, particularly for the discussion, I want to share some anecdata. So maybe some things where there's not as clear literature on, but some surgical approaches that I take myself, and this may affect the diabetic patient. So it may decrease the risk of complications in some way. Diabetes as a risk factor. So as we heard with these preceding talks, there's significant changes in the diabetic population relative to your healthy patient. The basic science on the right suggests some of these physiologic changes. And what our patients really want to know is how this affects their risks going into a prosthetic case. So typically about a 3 to 7% risk of infection is quoted, although I have an asterisk because you'll see some variation. Some would argue that there's really no increased risk in the diabetic population. Sometimes you'll see double-digit percentages depending on the studies, but I think that 3 to 7% range is pretty typical for what we would quote our diabetic patients. And that's in comparison to roughly a 0.5 to 2% risk in non-diabetics. Much of this comes back to the alterations in the normal course of wound healing and the patient's response to infection. there's a little bit of the physiology to the right suggesting some of the derangements that we see in our diabetics that lead to slower wound healing, poorer immune response, and we see that in our patients as an increased infection risk. There's many studies out there dealing with sort of trying to quantify the risk of infection in diabetics relative to non-diabetics. This is one study from a New York database that's commonly quoted. They look at nearly 15,000 patients. The interesting thing about this is it looks in the pre and post antibiotic coding era. So there's a cohort of patients that were operated on pre-antibiotic coding, and then a fairly equal cohort that had their operation post-antibiotic coding. In general, for both cohorts, diabetics had an overall infection rate, shorter median interval to infection, and lower infection-free survival. I chose this study because this chart sort of suggests that there's an immediate drop-off in infection-free survival. Most of these infections are occurring early in the first 3 or 4 months. So it suggests that if you can intervene early, that's the biggest potential for altering this infection-free survival, and that's whether the device is coated with antibiotics or not. So to take that one step further, the real question is, can we mitigate this risk by optimizing perioperative glycemic control? It's a little bit of a complicated question, and there's a lot of research out there, and there's a lot of debate about identification of the appropriate biomarkers, what cutoff should be used, does it matter at all? Can there be a categorical cutoff? Is it continuous? There's numerous studies out there, and I've selected a few because this study suggests in nearly 1,000 patients that there could be a categorical cutoff at 8.5% for the hemoglobin A1C, for instance. There are some problems with all of these studies, namely this one is somewhat criticized for primarily focusing on a semi-rigid device. Most devices implanted today, of course, are the 3-piece inflatable device with some sort of either antibiotic or hydrophilic coating. So it's suggested that this may not necessarily apply to our modern patient cohorts. There are several studies that say the exact opposite, one of which was a systematic review that actually looked at numerous studies assessing the role of both hemoglobin A1C and serum glucose levels as risk factors for implant infections. Across the board on these studies, they suggested that there was no support for a categorical or continuous cutoff for the hemoglobin A1C or serum glucose around the time of operation. And then in direct contradiction to the initial study, there was this study in nearly 600 diabetic patients that is somewhat criticized for maybe underrepresenting the infection rate because it's at 1% for all comers, including their diabetic population, which many studies would somewhat disagree with. However, they did find no use for this 8.5% cutoff for the hemoglobin A1C. This is just a small sampling of the studies that look at the biomarkers, but the point is there's a little bit of an unclear role of the hemoglobin A1C and serum glucose levels. There's a lot of heterogeneity in the studies. There's not a real consensus in the implant community about what the role is. And then maybe there's a role for the shorter acting biomarkers. So fructosamine, the 1,5-AG, some of these other lesser used biomarkers that have sort of a shorter duration of glycemic control that they're looking at may have a role in the future. So really we need to look at this further as a implant community and sort of get an idea of what may be the best glycemic control metric. To switch gears a little bit, for antimicrobial prophylaxis, this is another issue since infection is the primary risk that patients are worried about and we're worried about as implanters. How should we change antimicrobial prophylaxis, if at all, in the diabetic population? So this initial study just looked at adherence to the AUA guidelines in diabetic patients and saw if strict adherence to the guidelines resulted in any change in device infections in this population. It looked at 800 patients and looked at infection, explant, and revisions, quantified the rates, And then it sort of subcategorized those who were on AUA guideline recommended antimicrobials. The guideline group, interestingly, had a higher infection rate versus those on non-standard therapies, and it was reported at 5.8 times increase. So why might that be? We sort of need to identify that knowledge gap. So looking at a multi-center investigation of the microorganisms involved in penile prosthesis infection, they sort of tried to identify that a little further when taken in context with the following paper that I'll present. They actually looked at 153 positive cultures on explanted devices. And one thing that really stuck out was fungal infections, and that was alluded to earlier in some of the other talks. So these patients are far more likely to have an explant related to a fungal infection than we maybe previously thought on this cohort. And then interestingly, within the AUA and the EAU, there's not a lot of information regarding whether or not we should be putting antifungals in our preoperative antibiotics. So as you can see, none of the guidelines suggest any antifungal use, and only 86% on standard therapy of the organisms were covered based on this explant data. So looking further, should we use antifungals in the diabetic population? This was a study that looked across 26 institutions, over 200 patients, looked at demographic and clinical data at the time of explant. All of these patients received standard therapy for the most part. 91% were receiving either Vancgen or cephalosporin and gentamicin. And 12%, which is very similar to the previous study, were found to have fungal cultures at time of explant. When looking at this cohort, nearly 70% were diabetic. So there may be some role for this perioperative antifungal therapy in our diabetic population. Non-infectious complications, there's a little less information out there on these. However, as I mentioned in the outline, avoiding catastrophe, glands ischemia is one that's a catastrophic complication, and it's a little more well described than some of the other non-infectious complications, such as just your mechanical failure and some of the others. Now, when looking at acute IPP glands ischemia, they found that 81% of those patients were found to be diabetic. So it seems to be disproportionately involving the diabetic population. There were other risk factors, and it's a little more complex because the risk factors seem to be additive. Most people have at least two, sometimes multiple risk factors, because in addition to diabetes, many were found to have smoking history, existing coronary artery disease, or peripheral vascular disease, had previous explants, previous radiation. So the main thing to know with non-infectious complications, as far as the catastrophic ones, that we can see in our diabetic population, is glands ischemia. And remember, if the glands is dusky, if there's anything abnormal in the postoperative exam that would suggest this, it's the hardest thing to do on post-op day one, or even less than post-op day one when you're seeing a dusky glands. However, it's important to take it out. Anecdata, this is what some of the considerations that maybe aren't as evidence-based, but we maybe decide to do in our diabetic population relative to our normal patient cohort. Since we don't have a sort of identified A1C cutoff or any biomarkers that necessarily there's a consensus on, in general, I tend to focus on just seeing if they're making a positive change, if they're motivated, what their level of diabetic control is now versus a year ago versus 2 years ago. I try to see if they've reached a nadir, if they're making positive change, have good support system. So maybe they do have a little bit of an elevated A1C. Maybe it is above that 8.5, where there's some debate that that patient may or may not have an increased risk based on the literature. But some of those patients tend to not continue to decrease their A1C. So then do you not offer them an implant, given the sort of debate in the data? I usually will just, in general, take an assessment on a case-by-case basis and decide, you know, has that patient made an effort? Are they at what I think may be their best baseline? And then go from there. Additionally, I've, you know, adding fluconazole to the perioperative antibiotics, I think there's quite a bit of evidence for this. There's actually evidence of giving fluconazole to all comers, not just the diabetics, may decrease infectious risks. So I've actually added that to the AUA guideline based antimicrobials for my patients prior to penile prosthesis insertion. Another thing, so I sort of treat this as if I would with any patient with scarring or loss of compliance to the corpora. So I avoid upsizing the implant at the time of implantation. Sometimes whenever you're sizing the patient's corpora for the device, you'll be able to get a little stretch, maybe upsized by a ½ centimeter or centimeter in some cases. Some people are more aggressive than others. I tend to not upsize at all at the time of implantation in these patients. I also use longer acting corporotomy sutures. I actually use PDS for mine rather than some of the traditional Vicryl that some would use. And you can even consider a running closure. This all just gets back to perhaps the longer wound healing or slower wound healing in the diabetic patients because of all the physiologic derangements that I mentioned and others did earlier in the talk. Finally, getting back to the glands ischemia and some of the other risks. So I don't leave the device too inflated in the early post-op period. For my non-diabetics, I'll typically leave the device somewhat inflated for some compression and everything until their initial post-operative visit. I don't do that in my diabetics. I leave them down completely in most cases, or just a single pump or two to sort of minimize that risk of glands ischemia and any local tissue ischemia, the corporotomies as well, to sort of prevent cylinder herniation, perhaps. That's just another change that I make in my diabetic population. So in conclusion, diabetes is independently associated with both infectious and non-infectious complications. The infection risk is roughly doubled. That's important for the patient counseling for an initial implant. Serum biomarkers may or may not be unreliable predictors of infection. That's sort of debatable, and there's also an unclear role of other biomarkers. Perhaps some of the shorter biomarkers, if those are looked at, may be of some use. Fungal organisms are present in a little over 10% of all the explants, and most of those are going to be diabetics. So adding antifungal coverage for either diabetics or all patients, which there's some evidence for as well, may be the ideal management. And then non-infectious complications, remember the glands ischemia risk in our diabetics, because that's one of the devastating things that can happen afterwards. And then surgeons should consider some minor alterations to their surgical technique in the diabetic population. Thank you.
Great talk, Dr. Bernard. Everybody, thank you so much. Listen, this was just a wonderful. Dr. Yaffe and myself were talking offline at just how scholastic and academic this webinar is, and we really hope to get lecture series like this out to, of course, the SMSNA and the more general urology public, because it's lectures like these that really are eye-opening, even for those of us who are implanting and seeing a lot of the testosterone ED patients. I think I learned a lot tonight. So I want to thank everybody for taking time out of their busy lives and careers to come on this webinar. With that, we've had just a few questions here. If you're holding on to some and you're still listening in, please do throw it into the Q&A. Dr. Dobbs, I saw that you already answered Dr. Mohammed's question. Do you mind maybe just take 2 seconds and elaborate a little bit on his question? It was sort of an interesting question I think a lot of patients have had regarding dependence on these new GLP-1s, and any of your thoughts related to sort of dependence on these drugs for maintenance of their A1C and their weight, and of course, how you might think that would affect down the road sexual function.
Right. So I think that these are medications that need to be taken, I'm not going to say necessarily for life, but certainly in the long haul, because they have an effect on delayed gastric emptying or on decreasing appetite in the brain. So I look at it like I would look at a statin. If one stops taking a statin, the LDL cholesterol is going to go up. And that's probably where we are with this class of medication as well. The gastric motility is going to increase again if you stop the medication. So maybe the patient can reduce the dosage in the long run, but I think that most of these medications are going to be long-term treatments. It's not like insulin per se, in which somebody can lose weight and maybe there'll be insulin sensitivity come back. These are medications that will likely require almost lifelong treatment. Great,
thank you. I know Dr. Yaffe has maybe a few questions. I'll just ask one more as I'm sort of going in the order of the lectures. Dr. Yee, going back to your lecture, one thing that popped up, you sort of mentioned it very quick about PCOS, which is sort of more now it's well understood, but I think the sexual ramifications for that are maybe not as well understood. Are they diabetic related? Are they hormone related? Is it both? Do the sexual function improve with controlling of A1C and controlling of sort of their insulin levels? Do you know much about that, or can you answer to that?
So only from my experience in that, I think it is actually very heterogeneous. So many of our PCOS patients do not have metabolic syndrome. And then that was sort of the thinking previously, is that, oh, you have to have insulin resistance, you have to have obesity. There are plenty of PCOS patients who don't have that. For those who do, I do think actually the problem lies in that the treatment that is often given to our PCOS patients is combined oral contraceptive pills, and they actually have a lot of sexual side effects and sequela, decreased libido. Often, I mean, and I'm sure you've seen this too, as the conjugated estrogen then stimulates hepatic secretion of sex hormone binding globulin, and then therefore lowering free testosterone. And the sequelae of that in the vestibule is pain, dryness, irritation, recurrent UTI-like symptoms in the absence of actual infections. And that is very poor for affecting female sexual function. If every time you want to have sex, then you have a UTI-like syndrome, then you're probably not going to want to have sex as much.
Okay, great. Thank you.
So yeah, thanks, Seth. So wonderful talks. We have a very recognizable person in the audience here, as all of us know. Dr. Perelman is in the audience, one of the leading figures in behavioral and sex therapy. And Dr. Perelman has a question for you, Mike. What are your thoughts how diabetes impacts serotonin that reportedly seemingly is resulting in both premature and delayed ejaculation? Are there reasons to believe that diabetes can have a different impact on serotonin that might account for these differentiated responses and resulting dysfunction? And obviously the impact of neuropathy would predispose delayed ejaculation as well, but the premature ejaculation is more surprising, unless given its high prevalence in men generally, it reflects what one sees in the general population rather than being caused by diabetes. Dr. Perlman's own thoughts are that the decreased neurosensitivity and serotonin inhibition predisposes erectile difficulty, and to avoid that, if interviewed, we would find that men with PE are hyper-stimulating to avoid erectile loss, but ejaculate prematurely. Your thoughts? It's a long-winded question, Mike. We'll see how long your answer is.
Well, thanks for the question. I by no means are an expert in neurophysiology of serotonin, but I mean, right now, serotonin has been studied peripherally as a target because it has roles in metabolic regulation. Therefore, metabolic syndrome is really one of those part of the diabetes patients. We know that centrally, serotonin has plays an inhibitory role in the hypothalamus, but in the peripherally, that the activity is actually pro-ejaculation. So I think I don't really have a right answer for this, but I think in some men, serotonin could be beneficial in helping them with some of their delayed ejaculation or anejaculation. There's definitely, I think, having folks like you guys help us with many aspects of their sexual dysfunction really helps. There's definitely behavior therapy and various things that can potentially help them regulate some of their thoughts. So I think more work needs to be done in this area, but there are definitely data that shows on the peripheral side, serotonin can act as a more of an agonist activity peripherally.
Great.
Thank you. And I have a last question. Sorry, Seth. So John did a really good job showing a pragmatic approach to diabetes management in a patient with a coming in for an implant. So this question is really actually catered towards Dr. Dobbs. Dr. Dobbs, so John mentioned that we don't have the A1C may not necessarily be the best biomarker we have to predict implant or surgical complications and infections. We have the leading authority here. So what would you recommend would be a better test for us to use to predict the potential complications from infections? With regards to diabetes, we had a study in the past that showed that men who had diabetes-related complications, like were missing a toe or had diabetic retinopathy, et cetera, had a higher complication and infection complication with implants. But short of that, we don't have a really good test. I was wondering what you can give us some guidance.
We don't. There's glycosylated proteins that have been used as a measure. There's fructosamine, which is a shorter than high hemoglobin A1C. You could use over a week. But there's no one test that really has great predictive value. There's a lot of genetics here. I mean, not every patient gets renal failure, as an example. Only about 1/3 do. So for the same hemoglobin A1C. So I think you want someone going into surgery to be as maximally in good control as possible. But you might choose a number. I certainly would say 10% and A1C. But aside from that, we don't really have functional measures to say who's going to do better at surgery.
Yeah, and I was going to follow that up, John, with, at SMSNA, some people have discussed day of sugar levels. So when they walk in, they get a quick glucose stick, glucose above 150, glucose of 200, they're coming in uncontrolled. Is that something you've looked at, or is that something you take into account before saying, you know what, this guy, something doesn't feel right, his sugar's level really high, uncontrolled? Even actually at NYU, the anesthesiologist will either delay or defer the case for another day if the standing glucose level when he comes in randomly is too high.
Yeah, that was actually the serum glucose levels were looked at in one of the sort of retrospective, like the meta-analysis essentially, that looked at several studies, and it mentioned the heterogeneity. Part of that was if they did check serum glucose when, how soon before surgery? Is it the day before? Is it when they come in?
Right.
There was a lot of heterogeneity in that. So they sort of compiled it. There's actually a nice chart in there, but that I sort of omitted to sort of make it more succinct to fit the talk. But it actually goes line item by each study and exactly when they checked the serum glucose. Some of them appeared to have a correlation and some did not. But when taken as a whole, they didn't really find a difference in that serum glucose. But that's a good point. What cutoff would we use and exactly when would we check that?
Great.
Thank you, John.
So, yeah, we're wrapping up. I don't see any other. Oh, are there other questions here? Oh, Dr. Perlman said thank you. Thank you, Dr. Perlman, for that question. Everybody has been thanked for their great talks, and Dr. Yaffe and I really appreciate you guys once again taking time out of your busy schedules. Of course, we didn't have a talk. I was thinking usually we have a talk on Peyronie's and diabetes, which is a huge issue in many of our clinics. We have a huge population of Peyronie's diabetics, but maybe that's a talk for another time. Dr. Yaffe, any final words?
No, I just thank everybody. This was a wonderful webinar, and I'm going to encourage the SMSNA to propagate it because there's a lot of information that all of us would like to learn. And I think we were texting on offline that we're all very interested about what those new weight loss medications are going to be to testosterone levels down the road. We're going to see some data on that coming out in the future.
Everybody have a good night. Stay safe.
Yeah.
Tune into Sirius XM. We'll be on tomorrow night, 6 to 8 p.m. Same topics.
Right.
Bye, guys.
See ya.